Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi dan salam sejahtera. Nama saya Nur Zaidah binti Muhammad dari Jabatan Dietetik dan Sajian akan mempengerusikan CME pada hari ini. Yang berusaha pengarah Hospital Raja Perempuan Zainab II, Datuk Dr. Hajah Selasawati binti Haji Ghazali. Yang dihormati timbalan-timbalan pengarah, ketua-ketua jabatan dan seluruh warga Hospital Raja Perempuan Zainab II. Tanpa membuang masa, saya menjemput penceramah untuk sesi CME kali ini iaitu pakar pediatrik Dr. Wee Hui Suan yang akan menyampaikan ceramah yang bertajuk COVID-19 in Neonates, Should We Be Worried? Persilakan.
A very good morning to our pengarah, Dr. Selasawati, all the consultants, specialists, and my fellow colleague in HRPZ. My topic for today is COVID-19 in neonates. Should we be worried? So this is an outline of my presentation today. So I'll start off with an introduction and then I'll talk about COVID-19 in neonates and also what's happening in our local setting. So a bit of an introduction of COVID-19, which is a disease caused by SARS-CoV-2. Since December 2019, COVID-19 has become a worldwide life-threatening health issue, and WHO has actually declared COVID-19 as a pandemic since 11 of March 2020. And up till 15 of June 2021, the total cases of COVID-19 is up to 177 million, whereas in Malaysia, we recorded 673,000 cases. Total deaths due to COVID is up to 3.8 million, which accounts for 2.1% of all total COVID cases. And in Malaysia, the total death is actually 4,142 cases up till 15th of June. So early in the pandemic, the rate of symptomatic infection, hospitalization, and death were low in children when compared to adults. Data from China, children less than 10 years old accounts for only 1% of COVID-19 patients. USA reported that 5% of patients with COVID-19 were children, and Korean Center for Disease Control has reported that 6.3% of children and adolescents aged less than 19 years old were actually infected with COVID-19. So the question now is, are children really less affected by COVID-19? Well, this is still an ongoing debate. In the early phase of the pandemic, large epidemiological studies carried out by US, China, and Italy suggested that children comprise only 1 to 2% of all COVID-19 cases. However, these numbers heavily depend on the testing criteria, whereby in the early phase, testing was only done in individuals who were symptomatic or required hospitalization, which is less often the case for children. Some studies suggested that children and adolescents have similar viral loads and may therefore be as likely to be infected and to transmit COVID-19 as adults. However, reassuringly, transmission in schools from either children to other children or children to adults has been rare. Study also showed that the rise in the cases of pediatric COVID-19 correlates with the rise in the cases of COVID-19 in the community. Now, the next question would be, why is COVID-19 less severe in children? There are many postulations for this, which is further subdivided into two groups by Zimmerman et al. The first group being the factors that increase the risk of COVID-19 in adults. As we are all aware, SARS-CoV-2 can infect endothelial cells and cause vasculitis. With the aging process, there's increased endothelial damage, which is also related to underlying comorbidities such as obesity, diabetes, hypertension, chronic kidney disease, and also smoking, thus explaining why adults with comorbidities are at greater risk of severe COVID-19. Studies also showed that with increased age, there's increase in the expression and affinity of ACE2 receptor, which is a main receptor for the entry of SARS-CoV-2 into the human cells. Furthermore, the age-related changes in the immune system, including presence of non-neutralizing human coronal antibody, that will actually facilitate the cell entry and replication of the virus, which explain the increased susceptibility to severe COVID in adults. Besides that, the decline in innate adaptive immune function in adults also leads to reduced SARS-CoV-2 clearance. The chronic pro-inflammatory state associated with age also predisposes adults to cytokine storm, which is associated with severe COVID. Lastly, the vitamin D level in adults is low, and actually vitamin D has an anti-inflammatory and antioxidative effect. The patients with obesity and chronic kidney disease also has low vitamin D, which are both related to more severe COVID-19. Now, let's move on to the factors that protect the children from severe COVID-19. First, the stronger innate trained immune response in children leads to more effective virus clearance. On the other hand, the weaker adaptive immune response in children and lower pro-inflammatory cytokine response cause less hyperinflammation and thus less severe COVID in children. As children are more susceptible to other pathogens, the recurrent viral infection could also lead to epigenetic changes in the trained immunity, making it more effective in clearing SARS-CoV-2. Besides that, children has higher melatonin level, which will reduce the expression of ACE2 receptor, thus reducing the risk of COVID-19 in children. Furthermore, the more recent vaccination with live vaccines, e.g. BCG or MMR, might also have an off-target effect towards SARS-CoV-2 infection. Lastly, as children are predominantly infected by transmission from adults, due to the fact that children have less workplace, shopping, travel, and nosocomial exposure to SARS-CoV-2, the intensity of the viral exposure is much lower with a reduced pathogenicity. However, the weekly numbers of cases reported to CDC among persons less than 21 years old has increased over time. On the other hand, there have been increased numbers of children were tested and testing ability as the testing ability become more common and screening has been done for all close contacts regardless of the symptoms. Whereas in the early stage of the pandemic, testing were only done in symptomatic patients only. This is the data from UNICEF that showed that the total number of COVID-19 in 100 countries. This data showed that about 11.5 million children and adolescents had COVID-19, which accounts for 13% of the total 88 million COVID-19 in the 100 countries. This is an alarming number as the amount has doubled from the initial data whereby there were only 1 to 6% of children and adolescents affected by COVID-19 in the initial phase of the pandemic last year. This is another data from the UNICEF that showed about over 7,100 children and adolescents died from COVID-19, which accounts for 0.3% of the 2.4 million COVID deaths in 78 countries. So what about in Malaysia? Up till 30th of May 2021, there were 82,341 infants and children had COVID-19, which accounts for 14.5% of our total COVID cases. In children aged 4 and below, there were more than 19,000 affected. Unfortunately, we don't have any data for the neonates per se. From the 82,000 cases, 27 children had to be treated in the intensive care unit. And there were 3 deaths due to COVID-19 from January 2021 to May 2021 for children less than 5 years old. This is an area of concern as there were only 3 deaths in this age group due to COVID-19 over the whole year of 2020. So what about COVID-19 in neonates, which is defined as infants less than 28 days old? The data for COVID-19 in neonates is still scarce. Now the question would be why we are so concerned about neonates and consider them as a separate population, mainly because their exposure to SARS-CoV-2 infection is different from children and adults. And besides that, neonates also has lower immune response compared to children and adults. And furthermore, the long-term impact of COVID-19 on neonates and even children is still uncertain. There are case series from multiple centers in the US reported that infection rate range from 0 to 12% among infants born to women with COVID-19 at delivery. A surveillance done in the UK by Gill et al. Showed that the incidence of positive COVID-19 neonates was actually 5.6 per 10,000 live births, which has higher incidence rate in Asian and Black. So what is the impact of COVID-19 in neonates? Neonate can be affected by COVID-19 in various ways, namely indirect impact of maternal COVID-19 infection. Second, vertically transmitted infection, also known as placenta transmission. And third, the postnatal acquired infection, which can subdivide into early neonatal period following birth to a mother with positive COVID or late neonatal infection from the community. So I will first elaborate on the indirect impact of maternal infection. The American Association of Pediatrics showed that the maternal infection primarily but not exclusively symptomatic infection at the time of delivery is actually associated with increased risk of preterm birth and also perinatal morbidity. This is also shown in the UK obstetric surveillance system, whereby 21% symptomatic women gave birth preterm versus a background rate of preterm delivery of 8% in the UK, and 21% of infants actually needed an admission to a neonatal unit versus a background rate of neonatal admission of 13% before the COVID era. A systematic review by LOT et al. That included 192 studies showed that there was higher risk of preterm birth and also neonatal unit admission for newborns born to women with COVID-19. Fortunately, there was no difference in other perinatal outcomes. Now I'll move on to the second impact of COVID-19, which is vertically acquired infection. During the initial phase, Dong et al. And Zhang et al. From China described a total of 3 cases with raised elevated IgM levels in newborns born to a mother with COVID-19. This suggests of an in utero infection, as we all know that IgM antibodies are not transferred to the fetus via the placenta, and IgM do not appear until 3 to 7 days after an infection. Subsequently, case studies by Kussman and also Vivanti described intrauterine COVID-19 infection with positive nasopharyngeal swab and rectal swab at early days of life. Besides that, Vivanti also reported that the placenta showed intervillous inflammation, which is consistent with a severe systemic maternal inflammatory status triggered by SARS-CoV-2 infection. Interestingly, in Negeri Sembilan, there was a report of the youngest COVID-19 patient in Malaysia who was a newborn born prematurely at 29 weeks, who had 2 positive swab tests that showed increased viral shedding on the second swab, suggesting that it's an in utero infection. Interestingly, the initial IgM and IgG at birth were negative, but demonstrated a seroconversion at day 14 of life. This could be due to a delayed response in view of the immature immune system in a preterm baby. From the surveillance done by the British Pediatric Surveillance Unit conducted by Gale et al., 17 out of 66 babies were confirmed COVID-19 infection were actually born to mother with known perinatal SARS-CoV-2 infection, which accounts for 5.7% of total maternal COVID-19 cases in the UK. Only 2 out of 66 babies were considered to have vertical transmission, whereby 2 had the first positive swab within 12 hours of life. Surprisingly, the surveillance showed that 8 out of 66 COVID-19 babies had suspected nosocomial infection. And out of the 8 patients with suspected nosocomial infection, 6 were preterm babies that were kept in the neonatal unit since birth but diagnosed at day 7 of life. However, in short, we can conclude that transplacental transmission do occur, but certainly appears to be rare, as most placentas studied had no evidence of infection. The third impact of COVID-19 on neonates would be the postnatally acquired infection. From the surveillance in UK, 41 out of 66 babies were diagnosed at more than 7 days old with a median age of 9.5 days, suggesting that these babies contracting COVID-19 postnatally rather than transplacental transmission. Now we'll move on to the clinical presentation of COVID-19 in neonates. Meta-analysis of 74 studies conducted by Reschetti et al. Showed that 45% neonates with COVID-19 were actually asymptomatic. Even then, most of the COVID-19 neonates presented with non-specific symptoms which can mimic any neonatal condition. For example, a respiratory distress in a neonate, which could be due to RDS in prematurity or meconium aspiration syndrome in infants with meconium stained liquor, and so on. This is a figure adapted from Gale et al., which showed that the most common signs and the most common symptoms that were reported in neonates in COVID-19 include temperature instability and also feeding intolerance, which again is a non-specific symptoms which can happen in any neonatal sepsis. In this study, 7 out of 66 neonates with COVID-19 were actually asymptomatic, whereby all 7 of them were diagnosed less than 7 days of life. This actually suggested that late postnatal community transmission of COVID-19 has higher viral intensity, causing that particular group of neonates to be symptomatic. As we are all aware, SARS-CoV-2 can be a neurotropic virus. So what are the neurological manifestations of SARS-CoV-2 in neonates? So as we all are aware, in adults, the neurological manifestation is up to 36%, whereas in children, it was reported to be 1%. In neonates, the data is limited. There were a few case reports that describe neurological manifestation in neonates that include irritability, high-pitched cry, hypopnea, upward eye deviation, stiffening, lethargy, hypertonia, and opisthotonus. Interestingly, Vivanti et al. Reported that the neurological findings in a premature 35-weeker was due to cerebral vasculitis, as evidenced by the MRI brain findings, which was done at day 11 of life. Now we'll move on to the investigation that need to be done to diagnose COVID-19 in neonates. All infants born to mother with COVID-19 will need oral or nasopharyngeal swab for PCR within 24 hours of life after a bath to remove any risk of contamination, and if negative, to have a repeated swab after 48 hours, as some infants might have a positive test at a later time. 2 tests are ideal because a single positive PCR in newborn respiratory sample may indicate viral replication or a viral fragments acquired during passage through the vagina or the immediate postnatal environment, that we term it as contamination rather than true neonatal infection. This is evidenced by McDavid et al., whereby 9 out of 418 neonates tested positive within 24 hours of life, but only 7 out of 9 subsequently 7 out of 9 were tested negative on the second swab, suggestive of contamination. This is a busy table that I adapted from WHO that actually showed us how to differentiate an in utero, intrapartum, or postnatal neonatal COVID-19 infection. So to summarize, if the baby had a first positive swab within 24 hours of life, but subsequent swabs at day 2 onwards were negative, then it is likely to be a contamination rather than a true infection. However, if the first swab within 24 hours and subsequent swabs after day 2 and day 5 of life were positive, then it's confirmed that the baby had a in utero transmission of COVID-19. On the other hand, if the baby's first swab within 24 hours was negative, but the subsequent swabs that were taken at day 3 onwards were positive, then we'll treat the baby as an intrapartumly acquired COVID-19. And if the baby's first swab within 24 hours was negative, but the first positive swab is actually after 48 hours of life, then it's highly likely that the child had a postnatal acquired infection rather than a in utero or intrapartum infection. So now we'll move on to the management of COVID-19 in neonates. As I mentioned earlier, most neonates with COVID-19 are asymptomatic or with mild symptoms that not require any treatment. So in the surveillance done by the BPSU in the UK, 28 out of 66 babies with COVID-19 required respiratory support, which make the incidence of 2.4 per 10,000 live births. In the surveillance conducted in the UK also showed that only 3%, 3 out of 66 required ventilation, which accounts for 5%, and 1 being preterm. And there were 15% that needing non-invasive ventilation and 33% needing supplemental oxygen. 2 out of 66 babies required antiviral and corticosteroids, which accounts for 3% of the total numbers of infants with COVID-19. So talking about specific treatment for COVID-19, the evidence is still lacking for neonates, even in children. However, most children with COVID-19 recover with supportive support, namely paracetamol, oxygen supplementation, NG tube or IV drip if the child cannot tolerate orally, and in antibiotics if there's a concomitant bacterial infection. Regarding steroids, though it is associated with decreased mortality in adults, trials in children are still ongoing. Thus, if we decide to give a steroid to a COVID-19 patient in children, it has to be a low dose for a shorter duration to prevent secondary bacterial superinfection. There are a few situations that we will consider steroids, which include underlying medical condition where steroid is needed. For example, exacerbation of bronchial asthma, relapse of nephrotic syndrome, or maintenance therapy for specific disease such as SLE. And a situation that we will consider steroids also include stage 5 COVID-19 or stage 4 with increasing supplemental oxygen, or worsening lung function at least 7 days from beginning of the symptoms in association with the increased inflammatory markers. This is a table adapted from our MOH guidelines for management of COVID-19 that showed the suggested dose of steroid to be given to children according to their weight. So namely dexamethasone, methylprednisolone, prednisolone, or hydrocortisone. What about antiviral for COVID-19? Again, the evidence is limited in neonates and even in children. So based on our MOH guideline, remdesivir is a preferred one due to the positive outcome in adult studies, which has reduced recovery time that appears to be well tolerated. However, this drug is not available in Malaysia. The second recommendation from our MOH guideline is antiviral is a combination drug of lopinavir and ritonavir, also known as Kaletra, which has been used for HIV infection. However, the syrup formulation for this drug actually contains 42% of ethanol and also propionylene glycol, which might not be suitable for our population. Furthermore, recent studies showed that there's actually no benefit observed with this Kaletra treatment. The next choice would be favipiravir, which is evidenced by a recent systemic review done by Manabi et al. Showed that this drug actually induced viral clearance by 7 days and clinical improvement within 14 days. So when we're talking about care in neonates, we were surely interested to know about the mother-newborn contact and also breastfeeding. So during the initial phase, China had been practicing immediate routine separation of newborns from mother with COVID-19 with no breastfeeding at all. Few countries recommended separation but allowed EBM, and US preferred EBM but allow mother to have breastfeeding if mother wishes to, but with good hand hygiene and mask. However, all these were during the initial phase of COVID-19 last year. So now the latest guidelines from WHO, CDC, and AAP now support keeping mother and baby together and encourage breastfeeding. The reason being is separating mother from her newborn is likely to have a detrimental effects in terms of mother-infant bonding, perinatal mental health, and also breastfeeding. And however, we have to be aware of the good the hygiene precaution, which include mask on, hand hygiene, physical distancing when baby is not breastfeeding. And so this is actually supported by the evidence of no viable infectious virus was detected in the breast milk thus far. And in fact, IgA and IgG antibodies specific to SARS-CoV-2 antigens were actually found in human milk in several studies in both maternal infection and also maternal vaccination patients. However, please note that separation may be necessary if mother who is too ill to look after the infants or neonates who require admission to neonatal care unit. What about the practice in Malaysia? This is a guideline for Malaysia which suggests that breastfeeding is not a contraindication if the mother is asymptomatic and can adhere to good hand hygiene, which include good hand hygiene, not kissing the baby, and put the baby back in the cot or incubator 2 meters away from the mother when the baby is not breastfeeding. However, this is not feasible in our local setting due to the overcrowded wards and patients' non-compliance to the mask and also hand hygiene in our community. Now we'll move on to the outcome of COVID-19 in neonates. So far, the evidence showed that there was no increased risk of congenital anomalies or stillbirth. However, a BBSU surveillance done by Gale et al. Showed that 24% were born preterm, and one had actually passed away due to condition unrelated to preterm. And they also showed that newborns who had early infection did better, with only one baby requiring ventilation, which is due to premature baby. And same with AAP, they also showed the evidence that newborn death directly attributed to perinatal COVID-19 is extremely rare in the US. Next, I will touch a bit on the possible complication of COVID-19 in children and possibly in neonates. So first, I would like to talk about multi-system inflammatory syndrome in children, which is also known as MISC or pediatric multi-system inflammatory syndrome, temporarily associated with SARS-CoV-2, which PIMS-DS in the UK. It is a relatively rare condition whereby there was the estimated incidence of 2 per 100,000 in the New York compared with incidence rate of COVID-19, which is 332 per 100,000, making it less than 1% of children with COVID-19 that has MISC. Interestingly, MISC has been reported more in children in Europe and North America, with lesser cases being reported from China or other Asian countries with high rates of COVID-19 cases. And the pathophysiology is believed to be due to immune dysregulation, whereby abnormal host immune response that cause abnormal inflammatory response to the virus. This graph I adapted from the CDC that showed the 3 to 4 week lag between the peak of COVID-19 cases within the communities and the rise of MISC cases, suggesting that MISC is actually a post-infectious process rather than an infection of COVID-19 itself. The clinical features of MISC may actually overlap with clinical features of severe COVID, but differ in the patterns of clinical presentation and organ involvement, whereby in severe COVID-19, children are most likely to have respiratory symptoms and they usually have underlying health condition, whereas in MISC, it happened in otherwise healthy children, and have more prominent gastrointestinal and cardiovascular symptoms. The clinical features also may be similar to those of Kawasaki disease or toxic shock syndrome. And some MISC will actually meet criteria for complete or even incomplete Kawasaki disease. And these cases have occurred in older children and are more common in Black and Hispanic. On the other hand, Kawasaki disease is more common in preschoolers and more common in Asian population. To confirm the diagnosis of MISC, we have to fulfill all the 4 criteria as stated by the CDC, namely age less than 21 years old, and with clinical presentation consistent with MISC, including all of the following, which include fever, the laboratory evidence of inflammation, multi-system involvement, which is defined as 2 or more organ systems involved, and severe illness requiring hospitalization. And third, there is no alternative possible causes for the symptoms, and there's also evidence of recent or current SARS-CoV-2 infection or exposure. Okay. Please note that these definitions are likely to change as more information becomes more available in the future. And in terms of investigation, all patients with suspected MISC should have been tested for SARS-CoV-2, including a serology and PCR. CDC showed that 60% of MISC have positive serology with negative PCR, whereas 30 to 35% have positive PCR and serology. Due to its multi-system involvement, a multidisciplinary team consisting of pediatric ID consultant, rheumatologists, cardiologists, intensivists, and also hematologists are needed. However, the treatment for MISC is mainly supportive. Unfortunately, we do not see any MISC in Kelantan yet, but there have been cases reported in Sabah and also Malacca. So the next complication will be the neurological impact on children due to the neurotropic SARS-CoV-2 virus. Singer et al. Reported 31 cases of post-COVID-19 neurological complications such as acute disseminating encephalomyelitis, which is known as ADEM, encephalitis, Guillain-Barré syndrome, seizure, or cerebral vascular disease. And there was also growing evidence that prenatal infection with enhanced expression of cytokines are associated with increased risk of autism spectrum disorder and also schizophrenia in the offspring in later life. Due to this, there are more ongoing studies regarding neonatal neurodevelopmental complications following COVID-19 are being conducted. The other complication that I would like to mention is long COVID, which is defined as a range of symptoms shown in this slide that can last weeks or months after first being diagnosed with COVID-19 or can appear weeks after the initial infection, which are not explained by any alternative diagnosis. So the most common symptoms that a patient with long COVID will describe would be lethargy and also loss of smell. So a study in the UK showed that 12.9% of the UK children aged 2 to 11 years and 14% of children aged 12 to 16 years have symptoms 5 weeks after the first infection. Another study in Italy suggested that more than half of the children aged 6 and 16 years who contract the virus have at least one symptoms lasting for more than 3 months. And 42% are actually impaired by this system during daily activities. So studies are also being done to look at the long-term effects of COVID-19 in children, not only due to the infection itself, but also the indirect effects of lockdown and school closure. So now let's take a look at the data from our local setting. This bar chart shows the total pediatric COVID-19 cases in Kelantan from early this year until 15th of June 2021. There's a spike of cases that correlates with the community cases since April 2021. It also shows that the total number of COVID-19 is more common in the secondary school age group. Again, the data for neonate per se is not available, whereby they only put as infants less than 1 year old. Among these, only a handful of pediatric patients less than 12 years old required hospitalization at our center. And this graph showed the total pediatric COVID or PUS patients that have been admitted to HRBZ since early this year. You can see that there was a rise of PUS admitted in May, mainly due to the rise of infants of positive COVID-19 mothers who need 2 negative swabs before they were discharged. Moving on to the neonatal COVID in HRBZ. From 1st January to 15th June of 2021, there were a total of 102 mothers with COVID-19 that gave birth to 106 live births with 4 sets of twins in HRBZ. However, only 3 out of the 106 babies had COVID-19 category 1, whereby 1 was in utero and 2 were considered as intrapartum, as they have a negative first swab within 24 hours of life. All the 3 of them required only nasal oxygen and were discharged well with follow-up clinic. There were also a total of 3 postnatally acquired neonatal COVID-19 that required admission to HRBZ from 1st to 15th June 2021. Out of the 3, only 1 required non-invasive ventilation and was eventually discharged well with follow-up clinic. Of note, there were also 2 infants of positive COVID-19 mother that required ventilation due to secondary causes, which is prematurity at 36 and 32 weeks respectively. So now the take-home message for today is, incidence of COVID-19 in children is especially in neonates is low. The indirect impact of maternal COVID-19 to newborns are related to preterm birth and also neonatal unit admission. Most neonatal COVID-19 are related to community transmission, and placenta transmission of COVID-19 is rare. Symptomatic neonate COVID-19 is also rare, and then most babies actually were mildly affected with good outcomes. However, the long-term effect of COVID-19 in neonates, However, the long-term effect of COVID-19 in neonates as well as children is still unknown. Therefore, vigilant surveillance is required. So let us all play our part by getting ourselves vaccinated, keeping ourselves safe, and therefore protect our children from the unforeseen complications of COVID-19. I'll end my presentation with a quote from the Secretary General of the UN. We are in this together and we'll get through this together. These are some of my references I used for my presentation, and I would like to thank you all for your attention.
What is the effect of pregnancy vaccination to the baby? Is there any effect now?
So far with the current evidence, okay, the question was whether there's any effect of vaccine to pregnant ladies to the fetus. So as far as I'm aware, because I'm not an ONG, but then from what I studied so far, there was no actually evidence saying that there's any effect to the fetus thus far. But if the pregnant lady wants to get a vaccination, they can still sign up for it, but then with certain types of vaccination, and they will be under surveillance for any symptoms later on for the fetus.
So no matter now they allow vaccination for pregnant mother regardless trimester, right? Or is it specific to certain trimester?
So, I'm sorry, I'm afraid I don't have I didn't read much about the vaccine in pregnant lady as such lah. But then as far as I know, they suggest that after the second trimester.
Okay, perhaps now we should do some surveillance on potential post-vaccination effect on new age. Because I think we should observe that whether it's happening or not in the hospital. Now we get those positive COVID, mother with positive COVID, we follow them through, and you can see that only 3 out of 100 are immune. But now we also need to follow that whether there is any significant illness for the baby post-vaccination. So far we don't see.
So far in our pediatric neonatal cases, we didn't see any effect from the vaccine and so on. Because I think in Malaysia we are not giving the pregnant ladies vaccination yet.
Yeah. Already pregnant ladies receiving vaccination.
I mean the one that already delivered.
Post delivery. You mean post delivery or pre-delivery?
Pre-delivery.
We already having pregnant ladies opt for vaccination before delivery. Right? Yes, we have super
40 minutes and above. So second trimester.
Yeah, so we need to monitor whether we hope there is no plasma center. Hopefully, this is something that we see.
Yeah.
So it's not easy to observe, especially at the early stage and you like whether they can, whether they affect the baby. So maybe you had a minimum.
Okay.
Can I just make a comment on that, on the issues regarding vaccination?
Yes, please, Dr. Nick.
Yes, I think what we want to stress is that although it's not that common that neonates is infected with COVID and they tend to have a mild disease, but we are seeing a different worrying trends, I would say, for this coming last few months, where the number of cases certainly has increased quite a jump from what we saw before. And it's not, although majority is still okay with mild infections, either asymptomatic or mildly symptomatic, but we've seen a more severe spectrum where neonates have to be ventilated throughout, not just in Kelantan, but also mentioned by other colleagues in other states in Malaysia. So far, Alhamdulillah, I think we haven't seen any death, but we do see those that have severe COVID with bad lung complications. I can mention now, even in Kuala Krai, the team there is ventilating neonates for the last more than 3 weeks now with severe bad lung that require prone ventilations and so on. So this can happen, and we can expect with the number of cases of baby born to a mother who's COVID positive, then even if it's the incident, if the proportion of babies that can get severe COVID is rare, but because of sheer numbers, we will bound to get cases where they have severe COVID, and we may not be able to support them because of the numbers. So I think what I want to stress here is that I think it is time for us to make sure that the pregnant mother get vaccinated. Certainly there are concerns regarding safety of the vaccines for pregnant mother, but I think we're getting more and more evidence that it is safe for the mother. Okay, in terms of theory wise, I think the vaccines that we are giving now is not live vaccines. The main concern with vaccinating mother is usually if we are giving live vaccines, but what all the vaccines that we have now, we don't consider that as a live vaccine. And we know that Pfizer vaccines has been approved to be used for pregnant mother, although for the other Sinovac and AstraZeneca, we're still waiting for the company's approval for the use, but I think on case-to-case basis it can be given. So I would be suggesting that we should be looking at make sure that we don't miss pregnant mother who is indicated to be vaccinated. We have this time period where the window period from the first trimester to 33 weeks for us to immunize the mother, so that we can prevent the babies from having the mother from getting the COVID, and hopefully preventing the babies to be to getting COVID, also, or being a PUS to a mother who's having positive COVID. And because the number of cases that we are seeing in HRPZ, majority, as Dr. B has mentioned just now, is PUS, because mom is detected to be positive during the time of delivery, and the management afterwards, the baby have to be admitted, have to have tests done, have to be isolated, and we have limited isolation facilities in our HRPZ, and that causes a lot more problems in terms of hospital management for this baby. So if we can prevent this by vaccinating the mother, both for us, it's basically for the baby's benefit, but in general, it will be benefits for the mother, because I think ONG side has shown in their guidelines that mother is at risk of getting more severe COVIDs for their own health. So we should be vaccinating, and I'm hoping that that this message come across, that majority of mother is not contraindicated for vaccination. They should get vaccinated, in fact, and we shouldn't be the one that actually prevent them from getting vaccination by giving them wrong information that the vaccine is not safe during pregnancy.
Dr. Nick, Dr. Nick, will the baby be partially immunized if when the mother is vaccinated?
Oh, we don't have that data, Datuk. We don't have that data, but we don't. We know for certain other diseases that we immunize mother during pregnancy, then we could protect the baby, like tetanus, and also for other infections that they're trying to put to give for like pertussis. Now they want to give an extra boost during the during the pregnancy period, but that's theoretically possible, but there's no data for that. This is that they're going to protect the baby for COVID per se.
Okay, thank you.
Boleh saya tambah sikit ke mengenai babies and the vaccination? I think as Dr. Nick cakap, we should encourage pregnant mothers who are actually at high risk. Most pregnant mothers sometimes obese, not related to the occupation. We have to look at that. But at the same time, those who actually have a baby or neonates with the congenital abnormalities and also had history of vaccination, it need to be reported to AEFI and PRA, as I've just said in the committee that we are considering to give some, I will not say a full compensation, but because we have areas of serious adverse event post-vaccination, and also permanent disability, some sort like should I say allowance, reimbursement, compensation, but this has been done in Singapore, Australia, UK, US. So I hope that the pediatricians whom actually have this, congenital abnormalities babies, referred to them, the history of vaccination should be taken. Although it is not yet reported, but this is under our surveillance, and we actually may end up paying the mother from 50,000 to 500,000, and that will probably be not paid to the maximum. So please notify, okay, regarding the babies delivered to mothers being vaccinated. It is under our surveillance. Thanks.
Thank you. Good. Any more questions? Okay. Okay, thank you very much for today CME presentation by Pediatric, Dr. Wee and the team, and of course Dr. Nikkei and also Dr. Maheran for giving their views. Yeah. So a few things, one or two. Number one, I hope that CME could be more interactive lepas ni ya. Dan saya hari ni pun I tried to go in and then I was given a notice that it's already exceed 100. So mungkin lepas ni boleh tambah lagi kot ya IT, more than 100 participant ya. Sebab tu saya naik atas ni. Okay. Number two, this is again everyone, kalau siapa yang dah baca ya berita semalam ataupun the day before, how it got viral, houseman kena saman ya kerana tidak patuh SOP. That happened in hospital Tengku Ampuan Najihah in Kuala Pilah, Seremban ya. So this are again, kita dah bagi pesanan ini dah setahun lebih dah, comply to SOP ya. So kita minta semua orang tag the My Sejahtera, declare your status ya. Dan kalau ada potential rasa-rasa symptomatic, declare yourself but don't take advantage on it ya. So kalau ada contact dan sebagainya, please declare yourself. Rasanya perkara ni ya lebih memberi pengajaran pada kita semua sebab dah setahun lebih dah. So we hope that we have cultured ataupun membudayakan pematuhan SOP dan sebagainya. Ya, saya rasa kita jangan isu ini menjadi, it is something to reflect on ourselves baliklah untuk mengingatkan diri kita. So My Sejahtera is so compulsory for everyone. Itu pun kita tak letak My Sejahtera di setiap ward lagi. Ya, kita letak dekat main entrance ya. Tapi if we should do that, then we should do that lah. But the bottom line is it must be from ourselves, daripada diri kita sendirilah ya. Dan we as a frontliner should be sangat-sangat vigilant benda ni kan. Macam mana kita nak menjadi contoh kepada orang lain, orang awam ya. Kalau kita sendiri yang berdepan dengan isu ni, very close to us, very near to us, and we are at risk all the time, tidak comply. Itu je lah pesanan saya ya. Thank you so much. We meet again next week insyaAllah. CME by? Okay, CME by dietitian next week. Thank you so much everyone. Take care, stay safe. Thank you. Okay.
Terima kasih diucapkan kepada Dr. Wilson di atas ceramah yang menarik dan informatif. Sebelum saya akhiri sesi CME kali ini, saya ingin menjamin tuan-tuan dan puan-puan untuk mengikuti sesi CME pada minggu hadapan by Jabatan Estetik dan Sajian. Dengan ini saya akhiri CME dengan tasbih kifarah dan surah Wal-Asr. Assalamualaikum.